Hello, everyone. Welcome and good afternoon. Thank you so much for joining this month's Fireside Chat titled Pathways to Prevention, Strategies to Address Cancer Disparities in Cultural Groups in Minnesota. This Fireside Chat is in recognition of National Cancer Prevention Month. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota. Our team's mission is to reduce the burden of cancer in Minnesota by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, the importance of screening and early detection, treatment options, survivorship, as well as clinical research opportunities. My name is Amna Hussein. I'm the Community Outreach and Engagement Manager on our team. And on behalf of our team, thank you so much for joining us today. As mentioned, this month, we recognize National Cancer Prevention Month, a time dedicated to raising awareness about cancer and the importance of prevention strategies in reducing the burden of cancer across our communities. Cancer affects countless lives, but does not affect all communities equally. Certain cultural groups in Minnesota face significant disparities in cancer incidence and mortality. So our session today aims to shed light on these disparities and discuss innovative research and community projects that are leading the way towards equitable solutions. In addition, taking a closer look at local cancer prevention resources. Today, we are privileged to have with us two esteemed experts who are at the forefront of tackling cancer disparities in our state. It is now my pleasure to introduce to you all our special guests, Drs. April Wilhelm and Serena Xiong. Dr. Wilhelm is a faculty physician and clinician researcher at the University of Minnesota St. John's Hospital Family Medicine Residency and the Program for Health Disparities Research. Prior to joining faculty, she completed an interdisciplinary fellowship in child and adolescent primary care research at the University of Minnesota. Her research program centers on promoting healthy behaviors among adolescents in refugee and immigrant communities and child and adolescent tobacco prevention and control. Welcome, Dr. Wilhelm. Serena Xiong is also part of our conversation today, and she is an assistant professor at the University of Minnesota Medical School Program in Health Disparities Research. Her research areas are in cancer prevention and dissemination and implementation science. In her professional role, she has been consistently implementing culturally responsive initiatives to address health inequities in Minnesota. Some of her contributions include developing culturally appropriate Hmong lifestyle guidelines for health practitioners in Minnesota, optimizing communication strategies for reaching at-risk Somali, Latinx, and Hmong elders with timely COVID-19 information, and leading the design of a website to educate Hmong parents and teens about the human papillomavirus vaccine, also known as the HPV vaccine. Dr. Xiong is a community engaged scholar and health equity researcher with a leading vision to advance health equity. We are just so honored to have them both here with us today to share more about the incredible work they are doing to address cancer disparities with communities to advance health equity in our state. So we will be recording today's session, so you can refer back to the recording on the Masonic Cancer Center's YouTube page. And you can also share out the recording to folks who you think might be interested. For University of Minnesota employees and spouses participating in the University of Minnesota Employee Wellbeing Program, I'm going to put a link in the chat shortly to complete the form to mark your attendance today. If you have trouble copying the link, we advise you to type the shortened URL into your browser. That will populate the form for you to complete. The link to the form will also be included in the post-event email that will be sent out tomorrow. So before I begin, I'd like our audience to get familiar with using the Q&A feature, which is located on the bottom right of your Zoom window during today's session. Please use the Q&A feature to submit your comment, reaction, and questions. We have time carved out at the end for some Q&A. Okay, so without further ado, I will pass it over to Drs. Wilhelm and Serena. The virtual floor is all yours.
Great, thank you, Amra. I think we'll just wait for you to pull up our slides here. Wonderful. Okay. Well, thank you again, Amna, for that kind introduction, and for the opportunity again for both April and I to present some of our research at this month's Fireside Chat. As Amna shared, today April and I will be sharing some innovative research strategies for how we are addressing cancer disparities in culture groups in Minnesota. Next slide. All right, so here is a brief itinerary of what April and I will cover in today's presentation. Of note, we will be focusing on cervical and lung cancer disparities. At the end of the presentation, we'll share with the audience some cancer prevention resources pertaining to these two cancers. So without further ado, let's delve into the topics. So to level set, I want to provide us with a working definition of what is meant by cancer disparities. So using the National Cancer Institute's definition, cancer disparities refer to differences in cancer measures such as incidence, prevalence, mortality, survival, morbidity, screening rates, stage of diagnosis, and survivorship. So these are differences across outcomes throughout the whole cancer care continuum. And so these disparities manifest across various population groups based on factors such as race or ethnicity, disability, gender identity, geographic location, income, education, age, sexual orientation, national origin, and other distinguishing characteristics. And so for the purposes of our presentation today, we will narrow our focus to exploring cervical cancer and lung cancer disparities within culture groups that are prevalent in Minnesota, specifically those who are Hmong or Somali. Next slide. So to gain a deeper insight into the context of cervical cancer disparities, let's examine the national landscape. So this graph comes from data collected in the Surveillance Epidemiology or End Results or SEER program, and it illustrates trends in age-adjusted incidence rates for cervical cancer from 2000 to 2020. And so notably, apart from the non-Hispanic, Asian, and Pacific Islander group, most racial and ethnic groups exhibit a larger or a higher incidence of cervical cancer compared to non-Hispanic whites. Next slide. Not surprisingly, when we look at cervical cancer mortality, we see a similar trend with most racial and ethnic groups experiencing higher mortality rates than non-Hispanic whites. Next slide. So at the local level, we also see similar cervical cancer disparities. So presented here are incidence and mortality rates for cervical cancer cases in Minnesota between 2015 to 2019. We can clearly see that non-Hispanic whites have the lowest incidence and mortality rates, whereas all other racial and ethnic groups have incidence and mortality rates that are nearly double that of non-Hispanic whites, with the exception of the Hispanic group. Additionally, it is noteworthy that at the national level, non-Hispanic, Asian, and Pacific Islanders appear to have a lower cervical cancer incidence and mortality rates compared to all other racial ethnic groups. But I want to highlight that in the state context, however, a cervical cancer disparity is apparent among Asian identifying Minnesotans. So now I'd like you to keep those numbers and statistics in mind as we shift our focus and examine disparities in lung cancer. So I'll hand it over to April.
Thank you so much, Serena. So we're also talking about lung cancer today, as Serena just redirected you to think about that. And it's really important to talk about lung cancer because it's actually the leading cause of death among men and women in the United States. This chart here looks at the rates of new cancer diagnoses over the period of time from 2016 to 2020 for lung cancer. And it's broken out by both men and women, men on the left, women on the right, and then by race and ethnicity. And one major takeaway is that non-Hispanic Black men have the highest level of new cases of lung cancer over this time period. So quite a disparity relative to all other groups. You'll notice that the levels of new cancer cases in other groups that are non-Hispanic white is the next group, but lower rates are present in Hispanic and non-Hispanic Asian Pacific Islander. And though these are relatively low levels, one thing I wanted to point out is that when we're only using racial categories to try to better understand disparities, it's quite limiting. And we have very little ethnicity data beyond the Hispanic category in a lot of these national data sets. So we can't really determine what the exact disparities are by ethnicity using national data. And we really need more ethnic level data to better understand the disparities. Next slide. In addition to experiencing disparities in lung cancer diagnoses and new cases, Black American men actually have the highest levels of mortality over this time period as well from lung cancer. And we don't know exactly what all of the contributors to this are, but some research studies have suggested that lung cancer screening disparities, which limits the ability to early diagnose these issues early on, and then also access to effective treatments may be driving some of these differences. Other mortality is quite low in some of the other groups, but this data is subject to the same challenges that I laid out in the new cases identification, which is largely restricted to racial categories here and not getting into more granular information that could help highlight disparities. Next slide. Now I want to look at more local data around lung cancer disparities. So here is a chart that depicts new cases in the state of Minnesota for lung cancer over a period of 4 years from 2013 to 2017. And as you can see here, the largest disparity in this population is actually American Indian and Alaska Native populations. They have a very large number of new cases of lung cancer in the state of Minnesota. Black Minnesotans also have a very high number of new cases. And while Asian and Pacific Islander and Hispanic populations have relatively low levels of new lung cancer diagnoses, they are both higher than the national averages for these populations. And so also are experiencing disparities in the state of Minnesota. This chart, again, captures a lack of very specific data within more specific ethnic groups, however. So, for example, we know very little about lung cancer incidence and mortality among Somali and among populations within the state of Minnesota because we don't collect that level of information within the state databases. However, we do know from cancer screening levels that there are likely to be disparities in the screening for lung cancer, similar to other cancer screenings, such as cervical cancer screening through pap smear and mammography. And so we anticipate that there are significant disparities in these groups, though they have not yet been documented. And now I'm going to pass it off to Serena to talk more about cervical cancer.
Thank you, April. So despite the prevalent and stark disparities observed in both cervical and lung cancer, it's essential to recognize that preventive measures can be taken against these diseases. So next slide. So cervical cancer prevention can be prevented in several ways with primary and secondary prevention efforts. So the primary prevention strategy centers around human papillomavirus or HPV vaccinations. And so this involves receiving inoculations targeting various types of HPV, which are known causes of cervical cancer, genital warts, and other forms of cancer. Currently in the US, HPV vaccination is routinely recommended at age 11 or 12 years. However, vaccination can be given as early as 9 years of age. Meanwhile, catch-up doses are recommended for persons 15 and older. And so those who fall within the 9 to 14 age range would receive 2 doses, and then children and adults who are 15 to 26 years of age would receive 3 doses. And then adults who are 27 or older will engage in a shared decision with a provider for catch-up doses. Next slide. Cervical cancer can also be prevented if screened and detected early enough. Currently, US women have 3 options when it comes to completing cervical cancer screening. They can undergo cervical cytology or a pap test every 3 years if the result is normal, or a high-risk human papillomavirus or a high-risk HPV test every 5 years. This is called the primary HPV testing strategy. Or they can do a combination of both. So high-risk HPV testing with a pap test, and both of those are normal results. They would repeat that every 5 years. Next slide. So despite the widespread availability of HPV vaccines, we still see disparities. So both initiation and completion rates at the national and state level fall significantly below the 80% target that's outlined in the Healthy People 2030 goal. The data presented here in this table is sourced from the Minnesota Department of Health's Minnesota Immunization Information Coalition, or MIC system, focusing on vaccine coverage among adolescents 13 to 17 years of age. So this analysis was conducted in 2022. As you can see, in comparison to other adolescent vaccines, such as Tdap and meningococcal conjugate, the uptake of HPV vaccine is notably low. Further, comprehensive data on HPV vaccination across disaggregated racial and ethnic groups is currently lacking. Of the available, local data, a clinic-based sample from a community health center in St. Paul, Minnesota, found that in 2016, HPV completion rates for among boys and girls were only 32% and 20% respectively. Next slide. When we look at cervical cancer screening, we also see similar trends of underutilization among racially and ethnically diverse groups. This disparity is especially pronounced among Asian females in Minnesota. In 2020, only 55% of Asian females had undergone a Pap test in the past 3 years. While not depicted here, it's also crucial to note that there are low rates of cervical cancer screening among first-generation American Somali women in Minnesota. So in most urban clinics, about 25 to 30% of Somali female patients are actively participating in cervical cancer screenings. Next slide. So there are many documented barriers to HPV vaccination and cervical cancer screening, and even in settings like the US where vaccines and screenings are widely available. These obstacles encompass factors such as shortage of time, transportation challenges, limited access to health insurance, distance to the clinics, scheduling difficulties, fear or embarrassment, vaccine hesitancy, limited English proficiency, and low health literacy. As we'll see in the next couple of slides that April will be presenting, these same factors also contribute to disparities in lung cancer screening and tobacco cessation uptake.
Thank you, Serena. So yeah, now I'm going to pivot into talking a little bit more about lung cancer prevention. And I've decided to focus a lot of this conversation around tobacco use because tobacco use is the leading risk factor for lung cancer, and disparities in tobacco use contribute to many of the lung cancer disparities that we see. So about 80% of lung cancer deaths are thought to result from smoking, and this number is probably even higher for specific types of lung cancer, such as small cell lung cancer. It's really rare for somebody who develops a cancer like small cell lung cancer to have never smoked. The risk of lung cancer for people who smoke is many times higher than for people who do not smoke. And the longer that someone smokes, and the more packs a day that somebody smokes, the greater their risk of developing cancer. And we often think about smoking as just being about cigarettes, but cigar smoking, pipe smoking, and other combustible forms of tobacco use like water pipes or hookah are almost as likely as cigarettes to cause lung cancer. If you don't smoke, breathing in the smoke of others, which is also called secondhand smoke or environmental tobacco exposure, can increase your risk of developing lung cancer as well. And in fact, secondhand smoke is the third leading cause of lung cancer among United States residents. There are lots of other causes of lung cancer out there as well. So another major concern that's been in the news and other commercials recently has been radon, which is a really common cause of environmental exposure in Minnesota. And radon is the second leading cause of lung cancer in the United States, and it's the leading cause of cancer among people who don't smoke. And just like there are disparities in tobacco use, there are disparities in radon exposure. But for the purposes of today's talk, since we have a limited amount of time, I'm going to be focused a little bit more on tobacco use disparities. Next slide. So in Minnesota, adults who identify as American Indian or Alaska Native are the most likely to smoke commercial tobacco products like cigarettes. Their levels of use are also higher among Minnesotans who identify as two or more races or some other race. Which leads us to wonder exactly who are in some of these categories. So again, a call for needing some more specific data to really better understand the landscape here. So I think taking this into consideration, we might better understand the landscape around the high levels of mortality, particularly in the American Indian and Alaska Native population, since we see that tobacco use is so much higher in some of these groups, but there's more to learn. And another thing to point out here is, just as I mentioned earlier, it's not all about smoking cigarettes. And so these data are really reflecting smoking levels, but there are lots of other forms of combustible tobacco use that increase your cancer risk. And so this data is missing some more context that's really important to better understand. Next slide. So one local example of a population with very high level of tobacco use is the Somali American community in Minnesota. So as many of you may know, Minnesota is home to the largest Somali American community in the United States. And this group also represents the largest African refugee population in the US. In the most recent data available, which unfortunately is dating all the way back to 2009, 24% of Somali adults and 44% of these being men reported cigarette use in 2009 in a study. In addition to cigarette smoking, shisha use is thought to be quite widespread. And unfortunately, I can't give you the specific numbers of what percentage of the population use shisha because there haven't been great quantitative studies with surveys to really get at that. But what we know from qualitative studies or interviews and focus groups with members of the Somali American community is that it is quite widespread to be used in home, often used by women and young people, and often used in the presence of other young people, including children under the age of 18. Related to this, secondhand smoke exposure is very common within Somali homes. So in another 2009 study with a large Somali component of the population, 1 in 3 of these study participants who identified as African immigrant women reported daily cigarette smoke exposure, and 1 in 10 reported daily shisha smoke exposure. So quite common for people growing up in these households to be exposed to secondhand smoke. There are lots of reasons why these disparities exist within this community. I think there really is a lack of culturally tailored cigarette and shisha cessation tools for the population to access. There are challenges with navigating the healthcare system here in the United States. Shisha, for one, is not particularly regulated when it comes to sharing information about the components of the products. And so there's widespread information gaps. And so many things contribute to these disparities. And we really need to better understand what some of these challenges are in order to develop resources and tools that can start to address these disparities in this group. And now I'm going to pass it off to Serena to talk about some of the interventions that are out there for these issues.
Thank you, April. So both April and I have shared some of the data and evidence for why cervical and lung cancer and tobacco use disparities exist for Hmong and Somali cultural groups. In the next couple of slides, we'll present some of the innovative research approaches that address and combat some of these disparities. So our first innovative research approach, Hmong promoting vaccines, is a community-based participatory research project that aims to target knowledge, self-efficacy, and shared decision-making around HPV vaccinations in the Hmong American community. The intervention itself is an educational website that was culturally and linguistically tailored to both Hmong parents and teens. The goals of the research project were to engage with the community to develop culturally tailored content and messages for the website, pilot test and evaluate the website with community members, and then work with community organizations to disseminate the website into the greater community. Next slide. So over the course of a year and a half, our research team and software developers worked together to prototype and iteratively design the Hmong Promoting Vaccines website. So what you see here are the final features of the website, which included 5 daily learning modules, which involved didactic learning with written text, visual pictures, and videos, along with interactive quizzes. The module topics were HPV infection and diseases, HPV vaccine, communication between clinics, parents, and teens, concerns about HPV vaccines, and finally, where to get HPV vaccines. The website was, as I said, culturally and linguistically tailored for both Hmong parents and teens. Parents could access the website and materials in both Hmong and English, while teens could view them in English. The majority of actors and actresses featured in the videos and images were all of influential community members, including a Hmong actor and a pageant winner. We were also intentional about creating an interface that reflects the Hmong culture, as evidenced by the Hmong-inspired color palette. The website also contained additional features such as links to HPV resources, a GPS locator for HPV vaccination sites, automated text reminders to finish modules, and to also schedule vaccine appointments, and then also access to a bilingual and bicultural navigator. Next slide. So we evaluated the website in 2019 with 29 Hmong parent team dyads, and overwhelmingly we saw very positive results. In both parents and teens, we saw increased knowledge about HPV and the HPV vaccine, increased concerns about HPV virus causing cancer in general words, and decreased concerns about harms of the HPV vaccine. We also saw communication and information seeking about HPV and H vaccination increase in parents, an increase in collaborative decision-making among both parents and teens, as well as an increase in both parents and teens' self-efficacy to get the HPV vaccine. Both parents and teens also reported a high acceptability of the website, and they were particularly fond of the representation of Hmong culture and actors and actresses embedded throughout the website. So now I'll hand it over to April to delve into the next phase of the study where we expanded the website's reach into the broader community.
Thank you, Serena. So next slide. So I'll be talking a little bit more about the dissemination phase of this web tool. And in this pilot project for dissemination, we were really aiming to promote the use of the website out among the people who it was built to use it. So among parents and adolescents, and we decided to focus the dissemination in schools and clinics. And so as a part of this project, we recruited 2 primary care clinics, 2 school-based health clinics, and 2 school health education classrooms. We met with them, we interviewed them, and we worked with them to develop individualized dissemination resources and strategies for how to best reach among parents and adolescents in those environments. And then we conducted an 8-week pilot study in the spring of 2022, where we let them use those materials over a period of time to see how it went and see how many people they could reach. And then following the pilot trial, we collected feedback and information on how things went to improve outreach down the road. In the second part of this project, we collaborated with 8 local and national organizations with the hope of exploring broader potential partnerships to broaden the reach of our dissemination efforts. And then also to really explore potential for long-term support for the website to kind of find the long-term home for the website that would allow it to be relevant and be maintained down the road outside of the research setting. Next slide. So here is an overview of who we reached with that dissemination pilot. Through our collaborations with these 6 sites, we reached 580 adolescents and/or adolescent parent dyads. And the range for the number of handouts that we distributed was quite large. So in one setting, we reached only 15 people, but in another setting, we were able to get 405. And the 405 number came from one of the schools that served the Hmong American Cultural Group. And we were really able to get to a lot of people there, which was fantastic. In the middle, you'll see the QR code hits. So we attempted to use the QR codes to have people use smartphones and get them directly linked into the website. And you can see that maybe this wasn't the most effective way to reach people. We only had 11 young people and 12 parents actually use the QR codes that were built into our dissemination tools. But despite this, we were able to reach 300 new users and used Google Analytics to better understand who was using our website during this pilot. And the average amount of time that each new user spent on our site was around 12 minutes, which we were really pleased with. It seemed like people were getting into the materials and making good use of this. However, through follow-up interviews at each site, we were really able to better understand the alternative strategies that we might consider, different messaging approaches for promoting the website, and other details that allowed us to better promote the website and develop some lessons learned in how the website could be best used in both clinic and educational settings. Next slide. Next slide. So here is an overview of who we reached with that dissemination pilot. Through our collaborations with these 6 sites, we reached 580 adolescents and/or adolescent parent dyads. And the range for the number of handouts that we distributed was quite large. So in one setting, we only had 11 young people and 12 parents actually use the QR codes that were built into our dissemination tools. And the average amount of time that each new user spent on our site was around 12 minutes, which we were really pleased with. It seemed like people were getting into the materials and making good use of this. However, through follow-up interviews at each site, we were really able to better understand the alternative strategies that we might consider, different messaging approaches for promoting the website and other details that allowed us to better promote the website and develop some lessons learned in how the website could be best used in both clinic and educational settings. Next slide. So we compiled all of this information into a dissemination toolkit linked here. And this toolkit highlights the strategies and materials that could be used to promote this website across both clinic and educational environments within the classroom. And we are currently partnering with multiple organizations to explore additional opportunities with how to get this website out there into the community, both locally and regionally, using this toolkit and some of the other resources that we developed, which is very exciting. All right, I'm now going to pass it off to Serena to talk about another local project.
Thank you, April. So our next innovative research project tackles cervical cancer screening disparities in Somali female patients. The ISBAR project, ISBAR meaning self-test in Somali, is a clinic-based intervention that entails the distribution of educational materials and an HPV cell sampling test kit to Somali female patients. So I provided an illustration of how to do the actual self-sampling with the test kit. And so HPV cell sampling is presently under exploration and testing in the US as a potential cervical cancer screening strategy. However, it is not FDA approved yet. And so the main goal of the ISBAR project is to increase cervical cancer screening participation among Somali women receiving care through primary care clinics in Minnesota through opportunistic or on-site HPV self-sampling. So next slide. So the study is still ongoing. So I'll just provide a brief overview of the study and some of the clinic partners involved. As I shared earlier, the educational materials will be informed by focus groups and interviews with patients and providers. Cervical cancer screening completion rates will then be evaluated pre and post implementation at the partnering clinics, including Smiley's Clinic, People's Center, and the Community University Healthcare Clinic, or COOC. And then additionally, semi-structured interviews will be conducted to examine some of the barriers and facilitators to the implementation of HPV cell sampling. And so the study is anticipated to conclude in December 2025. And so we encourage you to stay tuned for the results in future presentations. I'll now turn it over to April, who will share with us some of her exciting research projects about tobacco use cessation.
Thank you, Serena. So the project I'm going to be focusing our talk on today is one that was just recently funded and just kicked off at the beginning of February to address lung cancer disparities down the road. And that project is a collaboration with myself and WellShare International to develop and pilot test an intervention to reduce household shisha smoke exposure within Somali homes. And we were lucky enough to get a Masonic Cancer Center community catchment grant. So we will just be getting started on this work. Next slide. So in this project, we are hoping to address some of the challenges around shisha use and information out there about the risks of shisha use within Somali families. And so, as I mentioned earlier, there are gaps, as far as we know now, around secondhand smoke exposure understanding in general among Somali families, but also gaps especially around the perception of risk of using shisha products. Many people who use shisha among the Somali population do not necessarily understand that shisha is a tobacco product and that it has risks similar to using other tobacco products like cigarettes. And in addition to that, there is very little knowledge out there about, among, I should say, the researchers about who is using these products around kids and how they're being used in the home, and what parents' perceptions of the risks of using shisha products around their children are. And so this project aims to better understand the landscape around shisha use in Somali homes by first characterizing Somali parent knowledge and attitudes about shisha secondhand smoke exposure and their children. And then second, what are some of the barriers and facilitators to implementing a shisha intervention to reduce smoke exposure in the home? And we hope to use the information that we gain from this first part of the study to then develop an intervention that will be delivered by community health workers in the home that will both educate on the real risks of shisha and also help families to set up home smoke-free rules to reduce exposure of young people in the home to shisha, which will benefit the health of the entire family, hopefully. And then after we develop this intervention, we hope to test it out and see if it's feasible to move forward with a larger study down the road by working with 15 Somali families. Next slide. So as I mentioned, we just started working on this study in collaboration with WellShare. But over the next year, what we hope to do is recruit for participation in 4 focus groups with Somali parents who have experience with shisha, either who use shisha themselves or who have awareness of shisha use from family and friends. And as we also hope to better understand from the perspective of professionals who work within the Somali community or who serve members of the Somali community to get some differing viewpoints on what some of the challenges are with this particular issue and strategies to address it through an educational intervention. And we'll be then working with our community advisory board to develop the in-home intervention in year 1. Next slide. And then in the second year, we will aim to finalize and deliver the intervention to 15 families using the community health worker networks that already exist within the WellShare organization. And to better understand how well the intervention works, we'll be conducting pre- and post-test surveys on household tobacco use and whether or not home smoke-free rules are being used in the homes, both before and after the pilot. And then we'll also be measuring biomarkers of exposure for secondhand smoke exposure, either using urine or saliva samples from both one adult and one child in each family. And that will allow us to better understand how easy it is to collect these specimens and get some sense of how well this intervention might be working from a limited number of people. So I'm really looking forward to this study and looking forward to sharing the results down the road as we move forward. Next slide. Finally, Serena and I have compiled some cancer prevention resources, both at the local level and the national level, that we'd like to share. And we've linked these all, so they'll be available after the fact. But I'll walk you through each of them. So the first is through the Minnesota Department of Health for lower income patient populations who are either under or uninsured. There's a fantastic screening program called the SAGE screening program that helps to support breast and cervical cancer screening among women and also colorectal cancer screening. And so this is a program that's administered through federally qualified health centers and is just a really great way to expand cancer screening in the state of Minnesota for many common cancers. There is also a wealth of resources available through the Lao Assistance Center of Minnesota. Through a previous Minnesota Department of Health grant, this group developed a program that increases awareness of breast and cervical cancer, increases access and the ability to navigate the system, because the healthcare system is not that easy for people to navigate, and then also has initiatives to increase HPV vaccination rates among Asian American and Pacific Islander populations in the state of Minnesota. So just an excellent resource for people to explore there. And in terms of broader educational resources about cancer, the American Cancer Society is a national organization, but they have a very active Minnesota chapter. And so we've linked here some information from the American Cancer Society that has just a wealth of information about various cancers, as well as resources for those who may be newly diagnosed with cancer to support travel and emotional support and other things. We've also linked here at the National Cancer Institute. There are really helpful summaries of various types of cancer and appropriate screening tools that are all evidence-based. And that's the second link under educational resources. And then we linked the website that our research group developed, Hmong Promoting Vaccines, which it would be lovely if people wanted to check that out. We were really trying to get that out there. And next slide. And then finally, here is a list of both national and local tobacco cessation resources. So access to tobacco cessation is really a huge problem for many communities. And we have a fantastic free resource in the state of Minnesota, Minnesota Quit Partner, which we will link here. Minnesota Quit Partner is a free program that provides free coaching through phone calls and text message support, and also a 2-week supply of nicotine replacement therapy. And support is available in Spanish, Somali, and Hmong. And we're really, really lucky to have access to that. I use this for many of my patients who need additional support in quitting smoking, which is such a very challenging habit to break. Nationally, there are other culturally and linguistically tailored resources that I want to highlight. So the Asian Smokers Quit Line is similar to Quit Partner. They have a one-on-one counseling and free self-help materials, and their counseling services are available in other languages, so Cantonese, Mandarin, Korean, and Vietnamese. And then finally, Smoke Free Espanol is a tailored program for Spanish speakers that's available at the link here, and the resources are also both culturally and linguistically tailored for this population. So lots of great support out there, and hopefully some of the initiatives that we are also working on will help make this list down the road. Next slide. So with that, Serena and I will wrap up. We very much appreciate the opportunity to be here with you today and to share these resources and some of the research that we're doing in this area. And we look forward to answering your questions. Thank you.
Doctors Wilhelm and Serena Xiong, thank you so much for the wonderful presentation and for sharing some of the incredible work being done in collaboration with some of the unique cultural communities in our state. Your dedication to advancing health equity in Minnesota is truly inspirational, and we're just so grateful to have you at the University of Minnesota and for you to join the conversation today. So thank you so much for your time. So now as we transition into the next phase of our fireside chat, we invite you, our audience, to join the conversation. So this portion is your opportunity to engage directly with Doctors Wilhelm and Xiong. And so we invite you to submit your questions using the Q&A feature, and we will do our best to try and address as many questions as time permits. So feel free to start entering in those questions. I'm actually going to share get our fire going, because it is not a fireside chat for those of you who have attended previous fireside chat conversation without getting our fire started. So as I get that started, feel free to start brainstorming some of your questions, entering them in. We did have quite a few questions submitted through the Q&A, so we can also start with those questions as well. All right. Okay, so to kick us off, are there any specific culturally specific cancer nonprofits that you would recommend? So I'll hand this over to either one of you to answer.
Yeah, great question. Thank you for asking that. So the resources that April shared, the Lao Citizen Center of Minnesota is a nonprofit organization. And so they received the Eliminating Health Disparities Initiative grant from the Minnesota Department of Health to provide specific cultural navigation for individuals who identify as either Asian or Pacific Islander. And so a lot of that work is creating a coalition of Asian American women who can help provide navigation for women of those particular backgrounds to access breast and cervical cancer screening. I know that there is another nonprofit organization, Monk American Partnership. They've done a little bit of work around cervical cancer screening, but have phased out of that work, but they are also doing some tobacco cessation work as well. April, did you have other organizations that you wanted to share?
Yeah, not specific to cancer only, but there are a lot of great not-for-profit organizations regionally and locally here in the Twin Cities that do a ton of cancer prevention work in these communities. I mean, my partner, Welsh International, has already done a ton of work around tobacco disparities in the Somali community. They're the ones who did a lot of the 2009 studies to really identify this as an issue. So I would count them as a really great partner locally. But I am not familiar with a cancer specific organization. There's
I
just some
will.
people who are dabbling, I think.
Yeah, I'll add in there is the African American Breast Cancer Alliance. So that nonprofit is specific to African American women and men who have been diagnosed with breast cancer. So I'll put a plug in for ABCA. I do work closely with them. So that's one of our local groups as well. But thank you so much, Dr. Wilhelm and John, for those. So there's another question in the chat. Can you talk about your work with communities? How do you connect with them? What has worked and what has not? So either one of you can
Sure, I can
start us
take
off.
a stab at this first. So as I mentioned, our Hmong Promoting Vaccines project really aptly illustrates the principle why community leadership and involvement is so important to research. So as I mentioned, it was a community-based participatory research project. Essentially what that meant was that we had equal partners from the Hmong community who was represented on the research team. So in addition to ensuring kind of the equitable representation of community members, we also had a community advisory board comprising individuals with diverse backgrounds, such as parents, healthcare professionals, and teens. And so the role that our CAB played in developing and testing the website, giving us, strategies for where to best disseminate our website were, pivotal to the success of the project. And so I would say that, really with the help of our community research partners and our CAB, that we were really able to achieve a much more meaningful and deepened impact within the Hmong community. But, our entry point was really working with the community so that we can get, the trust building that happens with community organizations. So that was kind of our entry point into developing the Hmong Promoting Vaccines website. But community work is, very time intensive. I think there's a lot that needs to be laid in terms of a foundation that is built on trust. And so going in and not having an agenda, really just immersing yourself in the community, listening to the needs and interests of the community and having them shape and direct the research, I think was kind of key in that project. Did you want to share anything else, April?
Yeah, I was just going to echo a lot of the same things. I think I have very slowly been developing relationships over time among several of my community partners. And a lot of them have been very iterative, where I've approached them being interested in a particular topic and then have kind of transitioned what we've worked on together based on what really is the interest of members of the community and partnering around issues. And so I actually started out not knowing a whole lot about shisha, but much more information about adolescent e-cigarette use, and have kind of pivoted a little bit more into the shisha territory after that has been an issue raised to be more relevant for my Somali partners and something that they really wanted to tackle. So I think for me, being open and really responsive to the needs of what my community partners suggest has been the most fruitful. And that's been true across all of the community engaged relationships that I've had in research over the last decade.
Love that. Thank you both for your thoughtful answers. There is another question that was just submitted. I am part of the statistic in that I did not get an HPV vaccine when I was younger. So what is your advice for approaching this conversation with parents to ensure younger siblings get their vaccine?
Yeah, I think HPV is, unfortunately, has been one of those vaccines that has entered the conversation and had some messaging around it that can really serve as a barrier to effectively immunizing young people. And so my approach as a clinician is to really say, these are the things that you're due for. And hey, this vaccine prevents cancer. How cool is that? It's really good at preventing oral cancers and cervical cancer, penile cancer. We should get this in your child at this age because it's when it works the best. And really focusing my messaging around the cancer prevention aspects of the vaccine and how well it works to really reduce the incidence of cancer, while not focusing on some of the other things that sometimes people come in wanting only to get the vaccines that are due for school. And I say, oh, well, you're due for all of these, even though unfortunately HPV has not yet been one of the vaccines that are mandated for school attendance. I frame it as a cancer prevention vaccine and how important it can really be for the long-term health of my patients, as opposed to focusing on sexual transmission and that it's not required for school. And that messaging strategy has worked really well as a clinician.
Thank you for that, Dr. Wilhelm. There's another question I see. So Heidi is my colleague who's been kind of answering some of these questions and typing away. So thank you so much, Heidi. But there's another question that was entered asking about within the African-American age group between 30 to 50, what types of cancers are you seeing amongst this demographic?
So I don't know how to answer this question the most thoroughly, just because that wasn't the focus of preparing for this talk. But I will say that lung cancer is one of the leading causes of cancer among Black Americans. And so I would anticipate that that is quite prevalent. Although I don't know between the age group of 30 to 50. I do know that there has been an increase in incidence of both colorectal cancer and breast cancer among Black Americans, as well as other groups in younger and younger ages. And that's one of the reasons why they've actually advised going back to everyone getting annual mammography starting at age 40 and getting colorectal cancer screening starting at age 45, given the increased number of new cases of cancers. And there are disparities among Black Americans in these groups. So that might be, just off the top of my head without 100% confirming the statistics, some of the higher levels of cancer in this population.
Where can you find some of this information?
Oh, yeah. So a lot of the information that we got, we pulled off of its SEER data and available through the CDC or the National Cancer Institute. Those are really two great cancer resources. But American Cancer Society also has a lot of information about cancer levels, and the Minnesota Department of Health more locally. Serena, any other resources?
Nope, I think you've mentioned everything. Yeah, there's a lot of really great national registries, as well as, tapping into the state registries from the Minnesota Department of Health would be the best way to access more of those granular data.
Thank you both for that. So Dr. Xiong, this question is for you. You shared a little bit about the ISBAR project with Dr. Rebecca Pratt. Are there any preliminary results that you can share?
Yeah, I really appreciate that question. So from the ISBAR project, Dr. Pratt and colleagues have published findings from their interviews with providers. And so the results of that qualitative study reveal that, most providers and staffs expect patients to have kind of a favorable experience with HPV cell sampling, and that the integration of HPV cell sampling into existing clinic workflows would be pretty straightforward. However, there is a little bit of reticence from providers. They did express about, some concerns about the effectiveness of HPV cell sampling and the absence of doing a physical exam on patients. But as for the main results of the study, as I mentioned in my presentation, the implementation of the intervention is still ongoing, but Dr. Pratt and colleagues are hoping to analyze the results by the end of this year and have kind of a forthcoming publication.
Right, so Dr. Wilhelm, I'll actually have you answer this question, and then Dr. Xiong, you can chime in as well. So what are some of the ways that medical providers can help eliminate racial biases, especially with language barriers?
Yeah, that is a very important question. So I think one of the best ways is to, first of all, be made aware of the fact that that is something that's happening, whether explicit or more implicitly. Bias is so prevalent within our medical community. And so self-education and kind of being made aware that this is something that is an issue, first and foremost, I think is really important. I also think around the limited English proficiency and needing to navigate across language, better working with interpreters and really understanding how to effectively partner with medical interpreters is crucial. And this is something that we work with our residents each and every day to better communicate with our patients and and really use the interpreters that are present to both better understand the messages that our patients are telling us and how we might interpret them from a contextual standpoint, and also how we can better communicate to our patients. And Serena, what else would you recommend?
Yeah, those are all really great strategies. Again, this is, such a great and tough question because it's a challenge that we're still contending with in the healthcare space. And so I think a few ways that we can mitigate or minimize racial bias, particularly as it relates to language barriers are, in addition to working with interpreters, but really hiring a diverse staff that really reflects the linguistic and cultural diversity of the patient population. This can go, such a way in terms of facilitating better communication and understanding between healthcare providers and patients. I also think it's essential to train providers on patient advocacy. I think, providers should definitely undergo training on, patient advocacy, really emphasizing that patients are not just merely passive recipients of information, but also to avoid the assumptions that patients, just absorb information without it. They do have kind of their own agency. And so really encouraging patients to advocate for themselves and to express their inputs and their needs. And so really creating a welcoming environment for open discussion of concerns and also, this shouldn't be undermined by language barriers. And so I think these are, potential starters, but there's, a whole host of other strategies that can start thinking about how we can create a more equitable and respectful healthcare environment.
So thank you both so much. So I have one more question for both of you that I'll ask before our time is up. So from our conversation today, from what you've shared, what is the most important message or action item that you want to leave with our audience? Dr. Wilhelm, do you want to start?
I can go
Dr.
first
Xiong?
there. I think one of the biggest takeaways is that we need to be really mindful about how we are collecting information so that we can actually better understand exactly what we're dealing with. And I would say that both in terms of better understanding who is getting these cancers, who is doing the screenings, and what are the challenges and potentially ways to tap into strengths within these communities to really develop tools that work better for them. And without this information, it's just really hard to do that work. And so that's really the focus of a lot of the work coming out of the program in Health Disparities Research with Dr. Xiong and myself, and really an important part of the future.
Dr. Xiong?
I think kind of the most important action item I would like for the audience to leave with is really to print the list of resources that were provided in the presentation. We can't predict when someone might need support with cancer screening or tobacco cessation. And so having these resources at hand is crucial. So, while we not personally require these resources, your contribution in sharing them really plays a crucial role in all of our collective efforts to reduce cancer screening disparities. And so my understanding is that these slides will be provided to folks who attended. And so, print the list of resources, put it onto your bulletin board. You never know if you're going to need it.
Exactly. And these are free resources that are accessible to anyone. So thank you so much, both Dr. Wilhelm and Dr. Xiong. And as Dr. Xiong noted, the slides will be shared in the post-event email that will be sent out tomorrow. So we are out of time, but thank you everyone for your participation today, your engaging questions. And again, a special thank you to Drs. Xiong and Wilhelm for sharing all the incredible work that you both are involved in reducing cancer disparities in our state. So after the session ends today, Zoom will populate a window to complete a brief survey for us. We would greatly appreciate if you could just spare a few minutes to provide us with your thoughts and feedback about today's Fireside Chat, as it helps us continuously improve our offerings. And after submitting the survey, don't close the window just yet, because there is a link to enter a drawing to win a prize pack filled with goodies from the Masonic Cancer Center as a small token of appreciation for completing the survey. And also the survey link will be included in the follow-up email that will be sent out tomorrow. And lastly, join us for our next Fireside Chat on Wednesday, March 20th from 3 to 4 in recognition of Kidney Cancer Awareness Month. And please make sure to follow the Masonic Cancer Center on all of our social media platforms to stay up to date on our future announcements and upcoming events. from the Office of Community Outreach and Engagement. Thanks again, everyone, for joining today and tuning in. We look forward to your continued engagement in future Fireside Chats. Hope you have a wonderful rest of your day. Thanks again, Dr. Wilhelm and Dr. Xiong, for joining us today. Take care, everyone.